Yes, thank you, ladies and gentlemen, Chairman. Thanks for the opportunity to give another Institute report about the surgical success to treat atrial fibrillation in mitral valve surgery. As you know, and this is just to introduce my talk, we know that patients who have atrial fibrillation have an impaired outcome compared to patients who have preoperative sinus rhythm in mitral valve surgery. And one aim, of course, is also to approximate the survival curve of patients with preoperative AF to the curve of patients who have preoperative sinus rhythm. Of course, we have different opportunities and lesion sets available today how to reach this, and this is just the general principles of an isolated pulmonary vein isolation, a more complex pulmonary vein isolation with additional left atrial lesion sets, adding at least a box and also left isthmus ablation, and at the final step, the full Cox-Maze procedure, either by conventional or also by alternative techniques. As Gillianov and the Cleveland Clinic could show, for patients who receive mitral valve surgery, pulmonary vein isolation seems to be enough regarding the success of recurrence of AF if patients have paroxysmal AF, but not if they have long-standing or at least persistent AF. And for these patients, they recommended, and this is also, I think, now clear in the literature and in the clinical practice, at least one box in left atrial isthmus ablation to receive the same results as with the conventional MACE procedure. However, especially in the background of minimal invasive mitral valve surgery, it's important to remember the guidelines. They said that it's accepted to treat patients, to ablate patients if they're highly symptomatic and undergoing other surgical procedures. And if the patients are not as symptomatic as they are, or where we do not know whether their symptoms are more related to the mitral valve disease or to the AF, we should minimize risk to do not add additional risk for the patient during the surgery. And for this, we made an institutional analysis of 732 consecutive patients who having paroxysmal or long-standing persistent. There were only a minority of patients who had persistent AF we excluded from our analysis. And they received, beside mitral valve surgery, also a left atrial approach to treat atrial fibrillation. You can see positive protocol was clear with beta blocker, but not contraindicated, amiodarone in recurrent early AF after surgery, a liberal cardioversion, and also 24 Holter during the hospital stay before discharge. And follow-up included routine anticoagulation for at least 3 months, then according to the CHETS-2 score and other clinical points, and 24 Holters. Always, we recommended this always, but this was not only performed in a minority of patients, of course. We also send the patients yearly questionnaires and asked for sending us ECGs. This is the approach of minimal invasive mitral surgery. I'm sure all of you are familiar with this. We used the ATS Medtronic cryoprobe for the ablation, and the lesion set is shown here. You can see this is the minimum every patient received. This means they received a box lesion and a left atrial mitral isthmus ablation. Of course, because there are 14 different surgeons, there were some additional not standardized lines, which included first the epicardial line to the mitral isthmus for 2 minutes, also completeness of the bilateral pulmonary vein isolation, and also exclusion of the left atrial appendage and the lesion line. So this would be a full left atrial Cox if you would like. Now, regarding just very shortly the baseline characteristics between patients having paroxysmal and persistent AF, we can see there are, of course, some difference. I just want to go to the significant differences. Patients with the long-standing persistent were older. Of course, they had more diabetes and they had a higher risk score measured by the Euroscore, and also they had they were more on anticoagulatant treatment and digitalis. Looking to the cardiac characteristics, and again comparing paroxysmal and long-standing persistent, you can see that the history of AF is longer in the long-standing persistent group. I think this is normal. Patients with long-standing persistent had at least 10% sinus rhythm at admission due to cardioversion immediately before admission to our institution. And they had also a larger left atrium, which is also probably important. Of course, the CHETS score 2, which we used in this analysis, was higher in this patient cohort, and also the patient with long-standing persistent had a high incidence of tricuspid valve incompetence of at least grade 2 plus. Now, looking very short to the intraoperative data, this is probably only on the left side important. Operative time, cross-clamp time, as you can see, 22 patients received tricuspid valve repair as an additional procedure, and left atrial appendage was excluded in 18% of the patient, but this was nevertheless given to the discretion of the surgeon unless the patient did not have any thrombus formation in the left atrial appendage. Positive results. Interestingly, patients having persistent AF had a more prolonged hospital stay, a little bit more complications. They stayed longer on ICU and also in the hospital. They had a higher MACE rate and also a higher rate of rethoracotomy and reinterventions, which was interesting. Nevertheless, they end up both with a hospital mortality of 1.5%. Now looking more to the rhythm results, to the success, you can see on the left, just comparing patients with paroxysmal and persistent AF, you can see that the success, as so-called success in 24 Holter, that means that we do not find any episode of atrial fibrillation in the 24 Holters before discharge, was 16% in patients with, the recurrency of AF was 16% in patients with paroxysmal AF and 32% of patients with persistent AF, and this doesn't make a difference whether or not the patient received aortic valve replacement or repair. Looking to the last ECG before discharge, 82 versus 87 of the patients with paroxysmal had sinus rhythm in the last ECG, and if they have paroxysmal AF and if they have long-standing persistent AF, they had 68% sinus rhythm at discharge. Now looking to this final slide, which is not focusing on the AF success, but more on the mortality, because we had a lot of discussions in the recent talks regarding success and to document success of ablation procedures. I just use the survival probably as a surrogate for success of AF. And I will start, sorry there is not a pointer here, but I try here. Just here, this is the dark gray line, which documents our treated patients, our 732 patients who had AF with cryoablation. And you can see that their survival is more or less comparable to the survival of 1,700 patients in the black line who had preoperative sinus rhythm. We just compared regarding the survival. So there is no significant difference anymore. And we also compared this to a very small number of patients, 207 overall, who didn't receive any ablation therapy during a minimal invasive mitral valve surgery. And the difference, the survival difference between patients with preoperative AF getting treatment, AF treatment, ablation treatment or not, is significantly different, and there is obviously a survival benefit. And now looking only to the patients with long-standing persistent AF, because almost all patients who didn't receive ablation during the mitral valve procedure were on long-standing persistent AF with a large left atrium appendage, left atria. And also in these patients with long-standing persistent, there was a survival benefit by the ablation therapy, which I think is remarkable. We also made a follow-up of these patients regarding to different time points. This is probably the limitation of the study, not on a yearly basis, but just by one questionnaire regarding their recurrency of AF. And this was after 2.6 years in medium after time. And from our 75% feedback, 32% of all had some period of recurrent AF. This was not significantly different between patients who had preoperative paroxysmal or long-standing persistent AF. And finally, just making a risk analysis on this basis, which patient have a risk for recurrent AF during follow-up. This was age, bad renal function, preoperative tricuspid valve regurgitation, and also pulmonary hypertension. So this obviously seems to be risk factors. Looking to the surgical procedure, of course, patients who having tricuspid regurgitation had higher risk or higher incidence of tricuspid valve repair, and this was also a risk factor. And patients with sinus rhythm at the time of discharge, of course, had a higher, lower risk to have recurrent AF during the follow-up. So in conclusion, our early clinical results of paroxysmal AF patients is comparable to patients with sinus rhythm. Interestingly, patients with long-standing persistent AF had a more prolonged hospital stay and more complicated course. Using the isolated left atrial appendage concept in this minimal invasive surgery, the early success was worse in long-standing persistent patients compared to patients with paroxysmal AF. It's unclear for me actually at the moment if we add some additive lesions to, especially on the right side, would probably reduce the incidence of recurrent AF. This is not clear. Sinus rhythm at discharge predicts obviously freedom from AF recurrence after mitral valve surgery. And importantly, after cryoablation, long-term survival curve of AF was approximated to sinus rhythm patients, and this was significantly better than in untreated AF patients, indicating a survival benefit by the ablation in these patients. Thank you very much for your attention.